Okay everyone, well welcome to this lecture on ankle sonography. So this will just be a practical demonstration of an ankle ultrasound. It's a sort of standard ankle ultrasound that most radiology departments would perform again. So a quick anatomy refresh. We're going to be looking at some of the structures around the ankle. So to start with, we're looking at this anterior inferior tibiofibular ligament. Then we're going to look at the ATFL, or the anterior talofibular ligament. Then we're going to look at the CFL, or the calcaneofibular ligament. Now that sits underneath the peroneal tendons. So why that's important we'll see when we're doing the scan. Then we're going to go and look at, we'll follow the peroneal tendons down, especially the peroneus brevis, as it attaches to the base of the fifth metatarsal. And then we'll have a little look at the peroneus longus, but that ducts underneath the foot, as you can see here, and attaches across to the base of the first metatarsal. Then we're going to go to the medial aspect of the ankle, look at the deltoid ligament. We're going to look at this sort of this posterior medial aspect. So we've got tibialis posterior, flexor hellicus longus, flexor digitorum longus, and the posterior tibial nerve. Then we're going to look at the Achilles tendon, and lastly we will look at the plantar fascia underneath the foot. So let's get started. So we've got Omna here as our model. Thank you, Omna. So now, like everything, you don't need to drown the area in gel, okay? But you do need enough gel so that your probe can slide. I'm using a 17 megahertz probe. I find it works really well. But you might, depending upon what you've got available, you might be using 15, 18, 12 megahertz. Some people will use a little hockey stick probe. I find depending upon the hockey stick that you're using, the image quality may not be as good as the larger linear probe, but use whatever works best for you. I've got it on the musculoskeletal superficial preset, just because it's superficial structures that we're looking at. So a little bit of gel. You don't need to put the gel bottle on the skin when you're putting the gel on the patient. That way you can keep things a little bit more sterile. So the first thing we're going to look at is that anterior inferior tibiofibular ligament. So the way I find things in the ankle is by knowing what the anatomy is doing. So I know that we've got the tibia, the tough bone, we can see it here. Just lateral to that, we've got the fibula or fine bone, and that AITFL ligament is, you can see the orientation, it's this oblique orientation. So I'll find the tibia, go right down to the end, and then look for a little structure connecting the tibia to the fibula. Let's see how we go. So we've got, we'll just turn our 2D gain down a bit, it's a bit bright. We've got the echogenic crescent, which is the anterior margin of the tibia. So that's pretty good because the AITFL is quite superficial. Come down, down, down. You can still see the tibia through here. There's dorsalis pedis artery pulsating away. Put a little bit of colour on that, you can see that. Now we're getting close to the end of the tibia. There it goes, disappeared now. So we'll go back up a little bit. Move laterally on the patient, looking for the fibula. There's the fibula. So we've found the distal tibia, the fibula, and then we're looking for a fine bridge of tissue like a ligament, or it's actually, some people call it a syndesmosis, just a swelling between those two structures, and there it is. There's the AITFL, or the anterior inferior tibiofibular ligament. That ligament gets torn, and if it's not recognised, what can happen is the talar bone keeps pushing up between the fibula and the tibia. Really rapidly leads to joint destruction. So this is what you want to see. We'll zoom that up a bit. We want to see this fine ligamentous structure stretching between nice smooth cortical margins. If it's abnormal, it'll swell up, like 3 or 4 times the size, hypoechoic. You might see fluid sitting above it. This is what it should look like. So that's the first one there. I take my first image. Then I'd move down to the ATFL, so the anterior talofibular ligament. So anterior talofibular ligament stretches from the fibula to the talus, funnily enough. So the way I find that is I know that it goes from the fibula to the talus, so I find the fibula, go scan in the axial plane all the way to the end, and then move over towards the talus, and hopefully we'll see it. So if we just ask Omna to roll her ankle in a bit so you guys can see it. So here's our fibula in the transverse plane, coming down, down, down the ankle, waiting for the fibula up, losing contact there, so grab a little bit more gel. Fibula is just about to disappear because I can feel it. There it goes. So there's the tip of the fibula, move over towards the talus, and there's the ATFL ligament. So once again, a nice fimbrial structure, nice smooth cortical surfaces. There's no fluid above the ligament if this ligament's torn. If you've got a complete full thickness tear or grade 3 tear of this ligament, joint fluid can escape into the superficial tissues because this ligament forms part of the joint capsule. And that would be my next image. Then I would move a bit more posterior lateral, and we're looking for that calcaneofibular ligament. Now, remember how I said the calcaneofibular ligament sits underneath the peroneal tendon? So we've got our peroneus longus and our peroneus brevis. Let's just adjust things a little here. We've got a bit too much depth. We'll move our focus up, increase our 2D gain, zoom the image up. I might just increase my, oh no, we'll see how we go. So we've got our two peroneal tendons here. Here's our fibula, so we're in the axial plane. We've got peroneus brevis and peroneus longus. They have a common sheath at this level. Right, as we go further down the foot, they have separate sheaths. So we know that the calcaneofibular ligament sits between the peroneal tendons and the cortical surface of the calcaneum. So that's where we're looking. And we know that the orientation of the ligament is sort of more vertical than the horizontal orientation of the ATFL. So we know where the anatomy is, and we look and position our ultrasound probe accordingly. So in saying that, let's hope we can find it. So here's our peroneal tendons in short axis, here's our fibula here, scanning inferiorly, looking for a fine ligamentous structure that's stretching between or sitting between those peroneal tendons and the underlying cortical surface. And this is it here. This is our calcaneofibular ligament. Now this is a much longer ligament than the anterior talofibular ligament, plus we run into anisotropy as it's inserting onto the sort of posterior aspect of the fibular head. So this is the CFL ligament as it goes through here. Lovely. Next thing I would look at is the peroneal tendons. In saying that though, sometimes I will look at what I call the lateral calcaneocuboid joint. So this is the joint between the calcaneum and the cuboid. So it sort of sits in here. The reason I look at that is because if we tear our ATFL, that joint can also look abnormal. That ligament can be torn as well. So that's easy to find. So you find the calcaneum bone. So we can see the cortical surface of the calcaneum. We move the probe on the lateral aspect. We come across the cuboid bone here. And what we're doing is looking for a little ligamentous structure stretching between the two. So just through here. And we're looking to see if there's fluid coming out through that. You can stress that. You can put your thumb underneath and push on things and see whether or not that joint opens up. So that would be an image that I would include if the ATFL ligament was torn. So our peroneal tendons start up adjacent to the lateral malleolus. So the lateral malleolus is the lump at the tip of the fibula. Reason being is that your peroneal tendons, they're a little bit odd. Right, the peroneus longus can sublux into a torn peroneus brevis. So you can get what's called a split tear in the tendon. So if you get a split tear, there's a gap in the tendon. So the longus can move into that tear. So it gives the impression of three tendons. Right? So I come down, making sure the sheath isn't swollen, making sure the tendons have a nice fimbrial pattern, follow them around that lateral malleolus, keep coming down, trying to stay at right angles to them, and then they'll separate off, and you'll have the peroneus brevis come down and attach to the base of the fifth metatarsal. So if we go in longitudinal there, there's our peroneus brevis attaching to the base of the fifth metatarsal. So if we've got our little model here again, here's our brevis coming down and attaching to the base of the fifth. Now that's important to look at because fractures of the fifth metatarsal are quite common. So you want to look A at the cortical surface to see if there's any evidence of a fracture, and B, look at the tendon and see what that looks like. Now the longus dives deep and underneath the foot, so it's much more prone to anisotropy, so you really need to heel toe your probe, and that sort of wraps around and courses deep underneath the foot. It goes around to that base of that first metatarsal. So here's the longus through here. Then I would move to the medial aspect of the ankle. Now you might be wondering why I don't look at the anterior aspect, right? You certainly can look at the anterior aspect, you can look at those extensor tendons, but most of the pathology tends to be going on in that lateral or medial aspect of the ankle, as well as the Achilles and the plantar fascia, but at the ankle itself, most of it tends to be going on the lateral and medial aspect. So talk to your patient, find out where it's sore, and then tailor your scan appropriately. But typically in that anterior aspect, all I would be looking for is an ankle joint effusion. So we've got our distal tibia, we've got the dome of our talar bone. I'd be asking the patient to plantar and dorsiflex the foot, see if there's any increased fluid sitting in there, see if there's any loose bodies sitting in there, and then I would get an anterior view of the ankle. I mean, we can see the extensor tendons sitting over here, and they've got a nice fembreal pattern as well. So if we move to the medial ankle, on the medial ankle we've got our deltoid ligament. Now the deltoid ligament's an interesting ligament. It's very strong, so it's rare that you see much going on with the deltoid ligament. It's got three components, and it has superficial and deep component. You don't appreciate them on ultrasound, all the different components. So really what I do is I know that the deltoid ligament is this fan of tissue along the medial aspect of the ankle, and I'll just put my ultrasound probe there and fan around the medial aspect of the ankle, looking for any abnormality, looking for bowing of the deltoid ligament, because it should have a nice concave appearance. So if there's an ankle joint effusion, you can have bowing of that ligament. So we've just got our ankle rolled medially, lovely, thanks on that. An ultrasound probe sitting in here, and the deltoid ligament we know goes from the medial malleolus, so we're looking for this fine ligamentous structure coming down, and there's our deltoid ligament. See, it's got a nice concave appearance. So if there was an ankle joint effusion, here's the ankle joint here, that deltoid ligament can be bowed out. And then I just survey through the ankle, looking to see if I can see any abnormality. Good. And then I would just take an image somewhere like this, indicating deltoid ligament, so showing a few of the fibres and showing that it's normal. Then on the medial side of our ankle, this is when you have to remember the little mnemonic: Tom, Dick and a very nervous Harry. Right? So we've got our medial malleolus here. The first tendon is tibialis posterior. Right? So tibia and the posterior aspect, tibialis posterior tendon. And then, so that's Tom. Then we've got Dick, so flexor digitorum longus, and a very nervous, so arteries, veins, and nerves. So here's our large tibialis posterior tibial nerve sitting in here. So this is the one when they're doing plantar fascia injections. The needle will go in, and they'll inject local anaesthetic to surround that nerve to numb the heel. So there's your tibialis posterior. And then your flexor helicus longus. Helicus pertains to the toe. Right? That's quite deep. So the easiest way to find that is just have the patient wiggle their big toe. And then you can see stuff moving down here. Right? So then I go longitudinal at that point and look for something wiggling. There it is. There's flexor helicus longus. Right? And so that would be where I would take my next picture, in that tarsal tunnel. We can even see the retinaculum going over the top here, that's beautiful. And that retinaculum is what helps to hold the structures in place in the tarsal tunnel, so they're not subluxing. That tibialis posterior is not subluxing or dislocating over the medial malleolus. So if your patient comes in and says, oh, I can feel something clicking on the inside of my foot, well, maybe they've torn that retinaculum. Maybe the tibialis posterior is popping backwards and forwards, causing problems, and it might eventually tear. So invert and evert their foot. See, in Omnar's case, because it's normal, the tendon stays where it is, but in someone that's subluxing, you might see it popping in and out. If you're looking for subluxation, don't push too hard with your ultrasound probe, okay? Don't drive the probe in, because then your probe can effectively take the place of the retinaculum and hold things in place. So then I would go down the ankle. We've got our tibialis posterior here. Now, one of the important things you need to look at is what's called the spring ligament. Now, the spring ligament is a structure that helps to maintain the arch of our foot, or the spring in our foot. So here's our spring ligament sitting immediately deep to the tibialis posterior tendon. There's three components to the spring ligament. We can't see all three on sonography, but we can see this tibio-navicular component, and that's it there. We're looking for a black cleft going through it. You can see it's quite a large structure. Then I would look at the plantar fascia. So we'll get some of the gel from around there. Look at the heel. Right. So the plantar fascia, there are measurements of normal for the plantar fascia. Typically it's less than about 4 millimeters in size. Once again, I'm not a huge fan of measurements, but it's still good to know them, especially when you're learning musculoskeletal. I'm more interested that you look at the texture of the plantar fascia. It should look like a tendon or a ligament, okay? Alternating black and white lines. Should have a nice smooth curve. The cortical surface should be nice and smooth. And then we can follow that plantar fascia down towards the toes, where we can get little plantar fibromas, these hypoechoic swellings. So that's a lovely, normal, echogenic plantar fascia. And the last thing that we'll look at here is the Achilles tendon. So typically I will roll people onto their tummy to look at the Achilles tendon, right? But in this case, just for ease, we're going to just ask someone to roll their ankle out. That's lovely. So I'd have them lying on their tummy with their feet hanging over the end of the table. But in this case, we'll just externally rotate, and here we can see the Achilles tendon going up towards that musculotendinous junction. So remember, your Achilles is made up of the medial gastrocnemius, lateral gastrocnemius, as well as the deeper fibers of the Achilles of the soleal muscle. Some people may have the plantaris tendon embedded in the Achilles tendon as well. So here's our Achilles. We'll take that focal zone up. So because it's also called the triceps surae, so it's got three components, so that the tendon itself you can peel apart. Right. So as we follow that down onto the calcaneum, turn through 90 degrees, and there's a lovely normal Achilles tendon. Right. Nice fimbrial pattern. This is what we call Kager's fat pad. That's important to know about. Kager's fat pad can become inflamed with Achilles problems and give people quite a lot of pain. In fact, some people think that the fat pad gives people more pain than the abnormal Achilles. I should have said, always put your colour on things. Look for colour. Make sure your colour scale's appropriate. Right? 1.8 centimetres a second is good. All right? We're not looking at the femoral artery where the blood's booming through there. So you don't want this up around 35 centimetres a second. Nice slow flow. Don't push too hard with your ultrasound probe, otherwise you'll compress those tiny vessels. So I get an image there, down towards the insertion. Look at those fibres as they go all the way down, nice smooth cortical surface. Look at the Achilles in the body. Most Achilles pathology occurs in the body of the Achilles tendon, so make sure that this is nice and echogenic and that there's no fusiform swelling. And look for fluid back here. This is the retrocalcaneal bursa. This is where you can get a little bit of fluid. An ankle joint effusion, we tend not to get posterior ankle joint effusions because the posterior ligamentous structures of the ankle are much stronger and tighter, so the fluid doesn't go there. But on the off chance that you might see it, Don't confuse this posterior or this retrocalcaneal bursa with a posterior ankle joint effusion. Retrocalcaneal bursa is down near the bone. A posterior ankle joint effusion will be a bit more superior. And that's an ankle ultrasound. Thank you.